I hate video.
Weird. All right, so here we go. This is the Coach Haas podcast, sponsored by Sports Rehab PA, and today we have a special guest on. She is a board-certified assistant professor of orthopedic surgery at Thomas Jefferson University, specializing in sports-related injuries, knee, shoulder, and elbow, mainly with female athletes, and I'll let her get into a little bit more about that. I don't want to steal her thunder. I'll let her do her introduction. Mike, today we have Dr. Sommer Hammoud from Rothman on, so I'm going to let her do her introduction, and then we'll kind of get into some of the questions from there. Great. All right. Dr. Hammoud, welcome.
Thank you. Thanks for having me.
Anytime.
Yeah. So you want me to just give a little background?
A little bit of background on how long you've been doing it, what kind of got you into doing it, and kind of where you're at now.
So I'm almost 9 years into practice as an orthopedic surgeon, but have been doing orthopedic surgery for much longer. As you all know, our training is quite an extensive, many-year type of process. And I come from California. I went to UCLA. I played soccer there. And then I came to the East Coast for medical school and the rest of my orthopedic training. And I landed, here with the Rothman Institute. It's a really fantastic place. It's very special, and I'm really lucky to be here. So I specialize in sports medicine, in the care of athletes, but also non-athletes. Mainly sports medicine encompasses both the arthroscopic and open treatment and joint preservation types of procedures, basically trying to prevent the need for joint replacement surgery. So when it comes to the knee, everything from meniscus surgery, including meniscus transplants, cartilage surgery and cartilage repair surgery, fractures, ligament injuries, knee dislocations, ACL tears, tendon tears, it's just really anything that happens about the knee, realignment procedures, patellofemoral instability, just really the entire spectrum of diseases within the knee, and the shoulder, the same thing, kind of everything prior to joint replacement surgery with the labrum and stability surgery, AC joint reconstruction, clavicle fractures, any sort of rotator cuff repair, etc. So all of those types of joint preserving procedures is what my real expertise is in.
Wow, that's a mouthful there, huh?
Yeah, right.
That's amazing stuff. That's really cool. And you know what? It was funny because I was reading through there, and I didn't realize you did some stuff with the shoulder as well. I thought you were mainly with the knee, but there are some surgeries that you do with the shoulder as well.
Yeah, I would say that it's maybe almost 50-50 at times. Knee and shoulder. Most common surgery I do by far is ACL reconstruction. But probably after that is rotator cuff repair, actually. We do everything, and of course, the athletes, they're injuring everything. But the most common things that they injure that I'm treating involve the shoulder and the knee.
Gotcha. Okay. Real quick with the COVID thing, we know that everything was kind of on delay for a while there. Have surgeries started to pick back up, or are you still?
Right. So we have started elective surgeries again for the past few weeks. Governor Wolf gave us the okay. We are taking many precautions at the facilities that we utilize. Mainly, we are utilizing surgical surgery centers as opposed to main hospitals. There are some main hospitals in the area that are opening up to elective surgery, but initially it was first with the surgery centers that were opening up. They're a safer environment, obviously. We are testing everyone with COVID 48 hours in advance and then asking them to self-isolate and quarantine really more strictly than maybe they have been before surgery. It's very important that they don't get sick around the time of surgery because it can increase the risk of complications as it relates to getting anesthesia and things like that. So far, so good. Things have been going well. Patients are happy to be able to get their issues treated, and, as it relates to something that we're going to talk about ACL surgery. One young girl that I had who was waiting for surgery actually in New Jersey and actually came over to Pennsylvania because we had opened up prior to New Jersey. And she had her initial injury and no meniscus tears identified at the initial injury, but she had some instability episodes since in the time period that she was waiting for surgery. And she did have a meniscal tear noted at the time of surgery that was not present on her initial MRI. Again,
potential, scenarios that you could be seeing with some of these kids that were waiting for that surgery to happen.
Yeah, I think it's really hard, right, to tell young people that you have to not do anything, right? Don't run, don't jump, don't cut pivot too quickly. Kids are going to be kids. It's really hard to hold them back, especially when the weather is nice. So yeah, it's difficult, but so we're glad that we're able to treat those patients now, and really help them.
What are some of the common causes of the ACL? Since that's our main focus is
right.
Some of the common causes.
Yeah. So I think patients don't realize, I think patients think that it has to be something really traumatic, to happen. But the most common cause of ACL rupture or ACL tear, which are really synonymous terms, is something, what we refer to as non-contact mechanisms. So it involves, landing from a jump, decelerating, change of direction, pivoting. So those types of movements, and when people go into those types of movements and they don't have the sufficient control around their lower extremity, and their knee, as I call it, kind of falls into kind of this kind of knock-kneed position, it undergoes what we call valgus collapse. But when it falls into that position because of insufficient, core and glute strength, insufficient balance to kind of stay upright, not having a nice soft landing, good hip and knee flexion, things like that. Those are the types of things that predispose people to injury.
Gotcha. Mike, got any questions there?
So can you talk a little bit about what involves like the repair with these grafts? Because I think that the patients and even the parents of some of these athletes don't really understand. They know you take a graft from either themselves or someplace else, but I don't think they really understand like what that entails, how it's anchored in, why it's important. They have to go through these phases, why the rehab is really long, and why even though they might feel well that they can't go and run and do certain things just yet.
Right. So that's it's a lot, to go over what you just asked. So let's just start with the graft types. So if we're talking here mainly to patients who are under the age of 25 and or who are highly active in cutting and pivoting sports, such as basketball, soccer, avid tennis players, any sort of, higher level or regular competition in those types of sports, by and large, we are recommending that they use their own tissue for the reconstruction. The reason for that is that when you use your own tissue versus a donor, so your own tissue is referred to as autograft, auto meaning from yourself. Donor tissue is referred to as allograft, so it's coming from some other source. Just like people donate kidneys and other things, they can donate their tendons, their Achilles tendon, their patellar tendon, these various things that we can utilize in order to do ACL reconstruction. So there is a real overwhelming body of literature and research to support the use of autograft, your own tissue, in patients under the age of 25 because it leads to a lower re-tear rate. So your chance of re-tearing it if you use your own tissue as opposed to donor tissue is significantly less. There are reports that it can be at least 4 times as high of a re-tear rate if you use donor tissue versus your own. So it's a real dramatic difference. And so for me personally, I am not really even offering to high school, college athletes the use of donor tissue. The scenarios that we would are really in those patients who have had it's either it's a multiple revision type of surgery. It's in their second, third ACL. They're kind of bowing out of sports, things like that. So there are those various reasons that And it really depends. You have to look at the whole picture, what's going on in the patient's knee, any other things happening. So when we reconstruct the ACL, no matter what graft type we're using, we can use your own hamstring, your patellar tendon, your quad tendon. Those are the three most common. We have to drill tunnels into the attachments of the ACL on the tibia or the shin bone and the femur. It crosses in the center of the knee like this with the PCL. They're called cruciate ligaments, so the anterior cruciate ligament. So we drill a tunnel into the attachment of each one, and the graft gets passed into the knee joint. And either on the femur side, really on both sides, you can either fix it with what we call suspensory fixation, where it's like a metal button that's on the outside of the bone that pretty much just kind of holds the graft in place in the tunnel. Or you can use interference fixation, meaning you can put the graft up there and then slide a screw adjacent to it to hold it in place. So there's lots of options for fixation. Back in the day, even, things can be also used like staples. You can tie the sutures which are the stitches that you put through the graft when you pass it through. You can tie those over a screw and washer. There are really many ways. The most common are the button or the screw. So that's suspensory or interference fixation. And there are benefits to each. It's really more surgeon preference. They both perform very well. And so when you undergo ACL reconstruction, when you have, for instance, when you use patellar tendon, so you take the central third of the patellar tendon, you take a small bone block from the kneecap, a small bone block from the shin or the tibia, and so you have a graft that's bone on either side and your tendon in between. And so when that gets placed across the knee joint, you have bone inside each of the tunnels. So you have bone healing to bone. When you have screw fixation of that bone or interference fixation, it's the strongest type of fixation at time zero, or the moment that you wake up in the operating room. Also, bone integrates or heals with adjacent bone at a much faster rate than does tendon heal to bone. So that's something to know as well. So patients often say, well, if I use, cadaver tissue, I'll recover faster. And that really is not entirely true. You may feel better faster because it's less trauma to your knee, right. But the graft, because it's donor tissue and it's devoid of any live cells, etc., it takes much longer for it to incorporate into the surrounding bone in the tunnel. So it is actually weaker at later time points, up to 3 months, than if you use your own tissue. So bone healing to bone kind of gives you the strongest graft at various time points. Any graft type kind of has its downsides. So when you take a patellar tendon or a quad tendon, there is trauma basically, or to the quadriceps or extensor mechanism, and that atrophy, it really is hard to regain. I think even athletes are just really shocked at how long it takes for them to regain that quad muscle, that strength. And it can really, and studies have shown that it takes like 2 years to get it back to normal. It really does take an enormous amount of time. And so you can have issues with quad atrophy, which can result in some anterior knee pain, whether it's pain behind your kneecap or kneeling pain in the front of the knee because a piece of bone has been taken from the tibia. The incision is kind of close to the front of the knee, and so you can have incisional pain with kneeling down and things like that. With your hamstring, there is an incidence of hamstring cramping with sprinting types of activities. We tend to avoid it in patients who, and athletes that require really significant recruitment of their hamstring muscle in their sport. And so the hit to the knee, right? So the knee ends up filling up with blood from drilling the tunnels through the bone. There's atrophy of the muscles. There's anesthesia. We commonly use nerve blocks to numb the leg. That also causes a hit to the knee and the musculature. There's really a push in many at the professional level not to use nerve blocks for that reason. But But all these things, right, it's not, nerve blocks are not all bad. They're actually mostly good, because they help minimize the need for narcotics. They make you much more comfortable in the recovery period. And they really are one of the key ingredients to good multimodal anesthesia and good pain control surrounding surgery. But what takes so long, right, to be able to start to run and get back to your sports, mostly is the regaining of strength. And so the way I explain it to patients, and I usually test them at minimum 3 months, is the earliest that I'll let them start jogging. But I ask them to do essentially a pistol squat, and if they don't have sufficient strength or stability in order to do, a pistol squat going down maybe 70 to 80 degrees, then they're not ready to withstand the forces of running, which go up to 7 times your body weight. So your knee and the knee joint and all the forces going through it are 7 times your body weight. It's really, really dramatic. And so if you don't have the adequate strength and muscular tissue to absorb those forces, those end up getting transferred to the cartilage surfaces, to your patellar tendon. You end up getting patellar tendonitis and other issues that can be such a nuisance and can actually delay your recovery. So I'm always telling my athletes, trust me, you don't need to run to get back to your sport fast. You need to get stronger, Yeah.
So, real quick with that, this is like a debate that, I'm still trying to figure out. Hopefully you can help me with this. So I get the whole running when you get the amount of strength, but shouldn't we be looking to make sure that they're able to jump and land and absorb landings and maybe single leg light bound first before they even get into the running? Or is running just become more of okay, we've hit this mark, it's time to start running?
Right. I think it has a lot more to do with that. I think that when it comes to ACL rehab, I think you go into double limb jumping and hopping before you transition to single limb. I personally don't think that single limb hopping and bounding necessarily needs to precede jogging. I think that, in a controlled fashion that's worthwhile, but I don't think it's absolutely necessary to perform prior, in my opinion. I think it can get dangerous when you're doing, a single limb hopping, for distance, for instance. I don't think that should be introduced very early.
Right.
So yeah, I think in a controlled fashion, I think I agree with you. I would do double limb followed by single limb and then jogging. But I think they need to have sufficient. I mean, I assume if they can do a single limb squat, they probably can do a pretty good single limb hop. I would assume so. You probably know better. You're with them at that phase more than I am. But and my ability to test them in the office is significantly decreased versus what you're doing. So yeah, that's it for me. I mean, remember, there are some patients, they'll go back and they'll talk to their athletic trainers or their coaches and their other players, and they'll say, well, why are you waiting so long to run? And sometimes patients have different types of meniscal tears that actually require a longer wait period before they're able to withstand those forces. So things like meniscal root tears or radial tears of the meniscus. Those types of meniscus tears, for me personally, I'm usually keeping them on crutches for 6 weeks. And I'm really delaying the onset of running.
Can you explain to the listeners what those type of tears mean, so they understand when they hear that, and why that's important, why they can't bend the knee or do certain motions at that certain point?
Right. So meniscal tears in general, there's actually quite a bit of debate about whether or not you need to restrict motion or weight bearing and things like that. But there's not a lot of debate when it comes to root tears and radial tears. The idea being, your meniscus is a C-shaped structure. Most meniscal tears kind of occur in line with the curve of the meniscus. We call those longitudinal meniscus tears. So those tend to occur in the periphery of the meniscus. There's a good blood supply there. You only get a blood supply to around the outer 25 to 30% of the meniscus. So that's very relevant when it comes to, is this a meniscus tear that we can repair or not? Second, the biomechanics of that type of tear, when you repair it, if you have a tear that kind of occurs out here and you put weight down, it actually pushes the tear kind of together. Versus if you had a tear that kind of crossed the fibers this way at a 90-degree angle, when you put weight down, it actually would splay it apart. And so that's the idea of when you have a root tear, one of the attachments either at the front or the back completely separates from the bone and you have to put it back in. So as you can imagine, if you were to put weight down, it would want to kind of squeeze the meniscus out like peanut butter and jelly from in between two slices of bread, right? And so you don't want those forces. You want that meniscus to heal inside that bone. And so that's why we minimize their weight bearing for 6 weeks. And I typically limit their flexion to 90 degrees for the first 6 weeks as well. I kind of treat them like a meniscus transplant. So that's for me, how I manage those. They do heal. I just recently got to see kind of a follow-up MRI on a patient who had a root tear. We don't always get follow-up MRIs, so someone has to be in pain or, complaining of something. So, but I was just so, not like pleased with myself, really more just pleased with the technology and the ability to repair it, because it literally looked like a normal meniscal root. I almost forgot that I had repaired that. Wow. And it really just, makes you feel good, right? It makes you feel like, okay, so what I'm doing is really, really working. And I really saved this person's joint, and it's really satisfying. And it makes me feel good that I'm doing something positive for the patients, and you can see those results, So yes, these, the techniques, it's relatively new, just because the techniques had not been developed a long time ago. But yeah, they work really well. And I just think that that's important to kind of put out there, because sometimes it's hard for people to wrap their head around why is my surgery taking so much longer? Right. And I'm always trying to impress upon the patients how important their meniscus is to the function of their knee. Yeah. I'd much rather see an isolated ACL tear than a complex tear of a meniscus, in a young person.
Now, in terms of healing, I actually have a return patient who came from you. She just had rotator cuff repair, and she has a Regeniten patch in there.
Right.
Can you talk a little bit about what that is, and are you using that in the knee for anything at all, or is that just strictly a shoulder thing?
That's strictly a shoulder thing right now. It's a bioinductive implant. We can use it either in isolation for partial rotator cuff tears. Okay. It can also be used to augment a rotator cuff repair. There is a recent study that shows improved healing rates when you place the patch on top of how you just typically repair the rotator cuff. Okay. I tend to utilize it more when the tissue quality is not great. Okay. And when it's a larger tear. Sometimes I use more robust grafts to augment a rotator cuff repair if the tissue quality is not, it's one of those things where if I just feel like, this tissue quality doesn't seem so great, like I'm worried that the tendon might just rip through the suture before the patient. Yeah, it's just something that's not so great. And in those cases, I use a dermal allograft patch on top of it. So again, we have lots of things, really great technology and advancements, and
So you see a patch in the protocol on top of the repair type, that's going to definitely be slower progression because tissue quality, and then you see that patch there, so it's saying we need a little extra here. Go slower with the
right. So yes, it could be either, right? It could be a partial tear where the patch was just placed on top and the cuff was otherwise not touched, in which case the recovery is actually quite accelerated. Okay. But in the cases where it's augmenting kind of a larger tear or poor tissue quality, then yes, typically I will delay the onset of therapy until 6 weeks post-op.
Okay. Makes sense. Now, back to the knee with ACL, are there things that might happen after the surgery? Any things that you would be on the lookout for? Any type of maybe like complications, like maybe if, I don't know, sometimes they talk about the graft angle, maybe things being really tight, or there's that cyclops lesion issue, or something happens around the graft. Are there things that you would tell athletes or patients to look out for, something like that?
Right. I think for me, the most important initial thing after ACL surgery, and when I say initial, I mean like within the first 2 weeks, is regaining full extension. Right. So making the knee fully straight. And so that's really when I'm on guard. Obviously we're always on guard for infection and things like that, but the reality is the incidence of infection and wound complications is exceedingly low in ACL surgery. I mean, knock on wood, I've never had an ACL get infected. And when you look at large database studies, tens of thousands of patients, the incidence is about 0.3%. It's really unusual. So fortunately, we don't have to worry too much about infection. But really what we worry about most, at least for me, I worry mostly about range of motion, regaining that in the initial period, and then ultimately about re-tear, that not adequate rehab and recovery, and then, too early of a return to sport without sufficient rehab or restoring of neuromuscular control, and then that predisposing the patient to re-injury. So when it comes to range of motion, it's critical that the extension is gained right away. If the patient's having difficulty with knee extension, I tend to follow them very closely in the first 6 weeks. Usually I see them every 2 weeks. But if someone's not doing well on range of motion, I kind of show them how to stretch it, do the prone knee hangs in the office. I kind of read them the riot act. I kind of scare them a little bit. It's a little bit of a scare tactic, I think they just need to realize how important it is, and I always tell them, listen, if you are not able to get your knee fully straight or fully bent, you won't be happy with me, so you need to, I've never seen a more unhappy patient than a patient that doesn't get their range of motion back. I almost feel like in some ways it could be a more difficult complication than a re-tear, in some strange ways, because it really does affect every aspect of your functioning. There is a young girl, for instance, who was treated by another surgeon, had her knee in kind of a knee flexion, maybe about 5 degrees or so, was able to kind of go back to playing high school sports. And she saw me kind of close after the initial surgery. She wasn't able to get her full range of motion. We talked about it. And she decided, I really want to play high school soccer. And she came back to me 2 years later, just recently again. And she couldn't get her knee fully straight still. So we got an MRI, showed a pretty significant cyclops lesion. And to your point, a cyclops lesion, what that is when there's kind of extra graft tissue that kind of bunches up between the bones. So when your knees go to straighten, instead there's this glob of tissue there and you just can't get it fully straight. So that's what a cyclops lesion is. It's more common with certain graft types. It's certainly more common with soft tissue graft types like hamstring tendons. And it's more common in general with allograft because it tends to be more tissue than we would typically take from the patient. So the downside, right, the unfortunate part of treating her cyclops lesion was that because her knee was kind of in this flexed position and her knee was never getting fully straight, what happens is it ends up putting additional load in the patellofemoral compartment. Mm-hmm. And she actually had some areas on her trochlea of full thickness cartilage loss. And she's a young girl. So that's the negative of not being able to straighten your knee beyond function. I mean, she was able to function and get back to soccer, but she was never 100% comfortable with it, but she dealt with it. But the negative is that it can have a real detrimental effect on your knee. So extension to me, way more important than flexion. Flexion is much easier to regain with time. Extension is less so, hard to regain even with surgery unless there's a real reason like a cyclops lesion that's preventing it. So, yeah.
I know that we're pressed for time with you, so I do want to kind of just talk a little bit about the return to play part, because there is still a little bit of controversy, I feel like, with that. Mike and I have kind of talked about adding in 2 other pieces to that, one of those being a fundamental capacity screen that basically screens you to see if you can really if you qualify for the return to play test. And then we're still now trying to find a performance piece that we want to put on the end to see then basically, okay, you've screened and you've passed. You've done the return to play and you've passed, but now can you handle loads of stress and, change of direction and stuff like that? So, Mike, I'm going to have you kind of take a little bit more of that and explain that.
So what it is, Dr. Hammoud, is basically through functional movement systems. Gray Cook and those guys basically created a system to basically look at movement patterns. And the fundamental capacity screen is great because it looks at also, athletes can be very deceptive. They look really good when they move, but then when you load them or put them under higher forces, then you start seeing the deficits. So they do a motor control screen, which first screens ankle mobility, and not only to see open kinetic chain ankle mobility, but when you load it, are there deficits there to see what's happening when the joint's loaded? And we're finding in a lot of these soccer players specifically, they have some end range dorsiflexion limitations. When they go to do that single leg squat, they're limited and they're starting to feel some anterior pain in that ankle because they're tight. And then we look at their single leg squat and we want to see if they're symmetrical on both sides. So they'll basically do the single leg squat and they'll push a slider out. And we'll see if they can get within 4 centimeters of the same distance on both sides. And also looking at the quality of the movement or if they have pain. Then there's another component where you look at them in a plank position and they reach across to see their core control. So we look at that. We also screen the shoulder and wrist to make sure there's no other impingement issues or things there. So if they are stable there, then we say, okay, you're good with the ankle mobility, you're stable in single leg squat, core looks good. Now let's go look at some higher level stuff. So we look at what happens when you load these systems a little bit more. So first we will look at their squat pattern even before they jump. If they can't do a functional squat, they're definitely not gonna be able to do a jump and landing because now we're just gonna predispose them to even more injury. So we clean up the squat pattern and say the squat pattern is good. Now we look at the jump. So there's something now to look at basically the broad jump. So we see how much they could do with their hands and without their hands to see where they're generating the power from. We look at the quality of the movement, and if there is valgus and torsion, can they correct that? If they can't correct it or they have pain, we just nix the test and say we got to fix this first, then go and look at that. So before they even get cleared to jump around and do the stuff, these prerequisites have to be cleared up beforehand. Then the next component is you'll look at basically jumping off of one leg and landing on two and seeing what's happening with that expression of power. How well can they, produce that power off of one leg, and then the symmetry. Then you look at the double and triple broad jump, so their energy recycling ability. Now, what's their elastic component? So can they rebound off of that, which a lot of these sports require, especially basketball, even soccer, jump, get a ball, go again, and then see what's happening there. And then the one that sometimes they do really well with that, the one that catches them is the 2-1-2 bound. So as you jump off of basically two legs, land on one, and then go back to two, you see a lot of breakdown there. So if they can't do that without having pain, that is a big issue because that also translates even into a lot of running there too. So I know some of them are very anxious at the 16-week mark when they're feeling good. They want to go run, but Joe and I have felt that if we look at these things and we see they want to go run around, if they're not loading with these boundings and this energy recycling and that knee is collapsing in over and over again, is that going to cause issues? Because we see like when Joe starts exercising, a lot of them, they'll go back and run, then the knee swells up, they have issues, patella issues, and it's because when you look at this energy system and how they're doing it with the impact and energy recycling, it's not there yet. So we start retraining that. And then we noticed that the return to sport test, they compensate a lot because of the momentum. So the first test, they could jump far out on the one leg. You might see some deficits, but then they actually do pretty well when they do the triple jump, the crossover, and then the 6-meter one for distance, because they're just using any momentum and they're just kind of rotating themselves to get through it, compensation. And sometimes the more skill the athlete has, the better they are at compensating. So we dial it back and we found that this functional capacity screen is kind of a safety net to catch those things and to see those areas that we can work on before they do that. We just think that the return to sport test just wasn't sensitive enough. So now we do everything, this whole battery of exams where everything, really break it down, and we're finding all those things. And then it allows us to curtail our training program to them specifically so they know what they're doing, why they're doing, and then why they're going to the next level of progression. So it's not just like, oh, you know what, go do this, or yeah, I guess try that. There's rhyme and reason for why we're doing these things.
Yeah, I mean, I think that's great. As I'm sure you're aware, we've developed a return to play checklist, at the Rothman Institute. Mm-hmm. We kind of use the Delphi method. We came up with the test that we wanted to include based on consensus among the sports surgeons. And then we've actually tested it. So, and we are in the process of publishing it, but it's been presented at national meetings. We basically enrolled patients and tested them with the return to play checklist and followed them for re-injury of the same ipsilateral or the contralateral limb, and documented that. And then we looked at our historical controls. And we found a statistically and clinically significant reduction in re-injury risk to the same limb and the contralateral limb when they're required to pass the checklist prior to return to play. Typically, we allowed them to take the checklist for the first time at 7 months, and then if they failed it, they could retake it 6 weeks later after further rehab and training. So, you know, I think that it's all good. I think that you know, I think if you have something that you think is worthwhile, study it and kind of prove that it works.
We want to talk. We want to try to get more data collection on that, so we can bring it to to the surgeons and say, because I didn't even know that was actually being done. So that's pretty interesting. But yeah, I mean, even on the performance end of that, you know, obviously most of the kids I see are soccer players.
Yeah.
The performance tests that we were talking about seem to be a little bit more on their energy systems.
Right.
I think that you want to find something that kind of goes across other sports as well.
Yeah, sure. Yeah.
So awesome. Listen, I really appreciate your time.
Yeah, it's my pleasure.
Where can we find you?
So yeah, right now it's actually a little bit funky because not all of our offices are back open. So I'm not in my usual offices, and you know, no one really knows when things are going to go back to quote unquote normal. So right now I'm physically seeing patients in the Willow Grove office on Tuesdays, Center City on Wednesdays, and Ben Salem on Thursdays. And then come July, I'll also be seeing patients in Chalfont actually on Mondays, which is new. And it's just because of the Bluebell office where I normally am is not open yet. So that's, you know, I operate out of the Bluebell Surgery Center as well as the Ben Salem, the Rothman Orthopedic Specialty Hospital there.
Oh, she froze.
A little bit, yeah. She might have lost some connection.
Yeah, right at the end.
Let's see if she connects back.
Well, if we can't get her back on, that was Dr. Sommer Hammoud at Rothman Orthopedics. What a fantastic interview. That was good stuff. Very valuable information. I didn't know about the return to play at the end there, so that's an interesting piece there. what I'm going to do is we're going to cut this, Mike, so we don't have Dr. Hammoud's face stuck there. And I will reach out to her and I will thank her for coming on the show. And we will get back at it next week. And hopefully we'll get John back too. And we'll do some podcasting.
Oh,
there it is. There you go.
I don't know. You guys froze on me. I lost you.
We saw you froze, so we just kind of filled in a little bit there. And I was just kind of basically closing out the show, thanking you again for coming on. And a lot of valuable information, especially the return to play at the end there. I really didn't know anything, about that. And we've been over here banging our heads together, just trying to figure out some things. Because honestly, when some of these kids come and they're saying they're passing these tests, I don't feel comfortable,
Right.
So like, okay, so, and again, the surgeons are saying, okay, you're good. You don't have to see me anymore, but yet they still haven't had the return to play test.
Right.
So then they need to go see the physical therapist. And then Mike has sent 2 of those back based upon the FCS saying that, okay, they're still at high risk. They technically passed the return to play, but they're still at a higher risk. So they were a little bit confused with that. And I was just trying to explain to them that, like, listen, you can do a lot of things, but you're still going to be at a higher risk at this point.
Yeah. Where I believe that we can share the test with you. Initially, when we were studying it, we were not sharing it outside of the Rothman Institute, the actual test that we'd come up with.
Okay.
But I may lose you again because it's saying my connection is unstable. Sorry. But I'm pretty sure that I can share it with you guys. Right.
Awesome.
Yeah.
Well, again, so we don't lose you in connection, we will try to have you back on again. I thank you and enjoy your weekend.
Great, you too. Take care.
Take care.
Take
Bye.
care. Bye.
All right, Mike, I'll give you a buzz.